All right, to master skin infections for Step 2 CK, you can't just memorize a laundry list of rashes. You absolutely need a highly structured system. What we're looking at here is a dark mode board review matrix. It maps out the exact decision points and test day logic you're going to need to conquer literally any dermatology infection vignette they throw at you. So this 10-point framework is your entire diagnostic pathway. When you're reading a question stem, your brain should automatically be scanning for these specific variables. Think about it. How deep is the infection? Are the borders sharp or are they flat? Is there pus? What about the patient's immune status? We're going to use these exact branches today to systematically navigate through the highest yield derm infections. Let's start superficial with impetigo. We've got two main players here. First, there's non-bullous impetigo. That's the most common form, and it presents with those classic honey-crusted lesions, usually caused by Staph aureus or group A strep. Then you have bullous impetigo. This one is specifically caused by Staph aureus producing an exfoliative toxin A, which leads to flaccid yellow bullae. Now, for limited non-bullous cases, you just use topical mupirocin. But, and this is a big but, if the disease is extensive or if you're dealing with that bullous variant, you've got to step up immediately to oral antibiotics like cephalexin. The absolute crucial point here is visually identifying that presentation right off the bat. When you see that golden, honey-colored crusting, that is a dead giveaway for non-bullous impetigo. On the flip side, those flaccid bullae filled with yellow fluid along with the colorative scale where older bullae have already ruptured, that's your bullous form. Locking in this visual difference is exactly how you'll know when to pivot from mupirocin straight to cephalexin on the exam. Now, getting into the skin layers, this brilliantly illustrates the depth difference, which is honestly the golden key to differentiating erysipelas from cellulitis and an abscess. Look closely at how this works. Erysipelas sits high up, right in the superficial upper dermis and lymphatics. Cellulitis, though, dives much deeper into the deep dermis and subcutaneous fat. Meanwhile, an abscess is just a localized, walled-off collection of pus. Knowing exactly where the infection lives in the tissue perfectly explains the clinical signs you're going to see on the patient's skin. Notice how those anatomical depths translate into real-world symptoms. Erysipelas hits fast. I mean really fast. You get a rapid onset and early fever. And because it's so superficial, you get these raised, sharply demarcated borders. It's almost always strep pyogenes. Cellulitis, being deeper, is way more indolent. It brews over days, the fever comes later, and the edges, they're flat and poorly demarcated. And if the vignette happens to mention purulent drainage or pus, stop right there. Pivot straight to a Staph aureus or MRSA abscess. Okay, let's test this logic out real quick. Say a patient presents with a rapid onset, red, swollen lesion with sharply defined borders, and it's right on the external ear. What are we thinking for the diagnosis? The answer is erysipelas, and the key clue here is pure anatomy. You see, the external ear actually lacks a deeper lower dermis and subcutaneous tissue. Because cellulitis absolutely requires that deeper tissue to develop, it's anatomically highly unlikely to happen on the ear. So that sharp border, combined with that highly specific location, points you straight to superficial erysipelas. Now, let's see how risk factors build your clinical picture for cellulitis. While immunosuppression, things like diabetes, and chronic edema from venous insufficiency or heart failure are major setups, I really want you to zero in on the barrier breaches category here. Seriously, any microscopic break in the skin is just an open door for bacteria. And that brings us to this highly testable, absolutely crucial fact. Tinea pedis is a massive risk factor for lower extremity cellulitis. The dermatophytes themselves are non-invasive, sure, but they cause fissuring and erosions between the toes. So when a patient presents with a swollen red leg, the vignette will often subtly drop a hint about scaly, itchy skin between their toes. You have got to recognize that as the entry point for the bacteria. Now, what if the swelling isn't a bacterial infection at all? You've got to watch out for the trap of a large local reaction from a Hemopterous sting, like a bee or a wasp. If the stem describes massive contiguous swelling over 10 centimeters, the timeline is your absolute separator here. An Ig-mediated local reaction develops incredibly rapidly, within 24 hours. Cellulitis simply does not brew that fast after an insect sting. It needs a few days. So if it's day 1, treat it with cold compresses, steroids, and antihistamines. No antibiotics needed. Diving into dangerous anatomic locations, visualizing Ludwig angina reveals exactly why it is such a massive threat. What we're dealing with is a rapidly spreading cellulitis of the submandibular and sublingual spaces. The key thing to notice is how the infection physically displaces the tongue upward and backward, pushing it directly into the pharynx. Because of that precise anatomy, the presentation and your priority are completely unique. You're looking for a patient with a recent infected mandibular dental molar who now has a fever, drooling, that classic hot potato muffled voice, and tender indurated bilateral submandibular swelling. The absolute danger here? Airway obstruction. The action? You must intubate early if the exam is concerning. Do not, and I mean do not wait for the oxygen saturation to drop. Secure that airway first. Shifting gears to the intratriginous areas, the skin folds, we have hidradenitis suppurata. This whole process is driven by follicular occlusion and rupture, and it's often linked to smoking and metabolic syndrome. For Step 2 CK, you need to step up your management based strictly on severity. For mild disease with just a few isolated nodules or abscesses, you go with topical clindamycin. If it progresses to moderate disease, meaning you're seeing sinus tracts and scarring, you escalate to oral tetracyclines. And for severe, widespread disease, that's when you're reaching for TNF-alpha inhibitors like adalimumab, or you're opting for surgical excision. Also, you can't forget the systemic impact of this chronic disease. You must monitor these patients for two major complications. First, there's a risk of severe depression and even suicide due to the immense psychosocial and physical burden. And second, there's a very real potential for squamous cell carcinoma to develop later on in those chronically inflamed, scarred tracts. Still in the skin folds, but moving over to pediatrics. Your key decision point for decoding diaper and perineal rashes is, quite literally, the skin folds themselves. Irritant dermatitis is the most common, and because the diaper doesn't rub deep into the creases, it uniquely spares the skin folds. You just treat that with barrier cream. Candida, however, thrives in warm, moist creases, so it actively involves the skin folds, with beefy red plaques and satellite lesions. That needs topical nystatin. Finally, if you see a bright, sharply demarcated red ring right around the anus in an infant or school-age child, that's perineal strep, and they're going to need oral amoxicillin. Let's do another quick pause. You see widespread, firm, dome-shaped, umbilicated papules on an adult patient. What's the diagnosis, and what is your immediate next step in management? That presentation is classic for molluscum contagiosum. Now, while kids commonly get this and usually just need some simple reassurance, extensive lesions in an adult are a massive red flag. Widespread molluscum in an adult strongly suggests underlying severe immunosuppression, which mandates immediate HIV testing. And as a quick aside, if the lesions happen to be genital, you definitely must test for other STIs as well. Finally, let's hit the fungal branches of our algorithm. For the test, it's all about matching the classic descriptors to the diagnosis and treatment. See spaghetti and meatballs on a KOH prep with hypo or hyperpigmented patches? That's tinea versicolor. Treat it topically. A scaly patch on the scalp with hair loss and black dots? That's tinea capitis, and because it involves the hair follicle deep down, it absolutely requires oral therapy like grisafovin or terbinafine. Thick, brittle, discolored nails? That points to onychomycosis, needing oral terbinafine. And tinea pitties, just like we discussed earlier, gets topical antifungals and a strict recommendation to keep that footwear dry. Wrapping us up rapidly, you want to train your eye to conquer this entire clinical algorithm on test day by spotting these exact pivots. Assess the depth and borders to distinguish erysipelas from cellulitis. Check for purulence to lock in a staph or MRSA abscess. Recognize airway threats like a molar-sourced Ludwig angina demanding immediate intubation. Use the skin folds to efficiently decode hidradenitis versus candida. And always respect the timeline. Stings swell in under 24 hours, cellulitis takes days. Master these specific branches, and you're going to navigate any dermatology infection vignette with absolute confidence.